Welcome, everybody. We are so excited that you are able to join us this afternoon. Welcome to Health Advocate X's Community Conversations. I am Melinda Stewart, the incoming chair of this amazing organization. And today I'm going to be serving as moderator. We are joined today by Molly Lanziger, a, oop, lost my notes. I'm so sorry. Um, we are joined by Molly Lanziger, an independent health insurance agent for over 20 years, and her specialties include individual, small group, and Medicare. We are honored to have her speaking with us today to talk about this changing landscape of insurance and really helping us understand what this actually means for us as advocates, as family members, even as patients. So, welcome, Molly. Thank you so much for being here.
Thank you. I appreciate the invite, and it feels like a privilege to be among you all. I have been in some meetings back when Health Advocate X first started and have so much respect for what you all do. And if I can be of help in answering questions, I'm happy to do that.
Awesome. Well, we've got some questions for you. So, let's start with this. Does seem like every time we turn around, there is some new information, there's some new change. I know I recently just changed from one insurance to a different type of insurance, and now it's a whole new whirlwind. Can you give us a little bit of what you're seeing that's happening today in the world of insurance?
Sure. I will start with soaring costs. I'm sure you're all seeing this. And if you haven't yet, you will. It's coming. We are just flabbergasted by the numbers, by the rate increases that are showing up, and we're, a little bit stumped, like what is going on? And I've sat through numerous webinars and trying to figure it out. And I'll say that the very first thing that has really changed is, um, I don't know if I should call it access to care, or I'll say hospitals and practices getting bought by larger companies, such as private equity. And that's really changing how it affects the patient. And what we're seeing is anything with recurring revenue, like a doc who sees someone on a regular basis. This is what private equity is interested in. They want to purchase the practice. The docs then become employees of this new company. And it feels like to us as patients that we are lost in the shuffle. And in that process, it becomes more of a business than a practice. And you'll see changes in copays. Just kind of getting appointments is really hard right now. I'm sure you're hearing this too, but even a relatively emergent issue, it might be 2 months before you can get in. So we're seeing this trend of hard to get care and it's expensive. And this is affecting not just us as patients, but also employers that are paying for health insurance. It's affecting the carriers, the insurance carriers, as they negotiate with the networks. The networks are asking for more money, the hospitals are asking for money, and the carriers are passing on the increases down to us. And then in effect also our employers. So that would be the number one change that I have seen over the years. Number two is the drug spend. What the heck? I mean, these drug prices are so expensive. And I know politically we're trying to get a hold of the costs of them. The newest and greatest is the GLP-1s, which I'm sure you all are seeing and learning about, and the positive effects of them. From my perspective, they're expensive. $1,200 a month till end of time. Hard to say. We're told that there will be between 5 to 7 years by the time we'll start to see those numbers come down. We're starting to see some of the compounding pharmacies are doing their own versions, and those are a little bit cheaper. Mostly what we're seeing in the health insurance part of it is that the carriers will cover if there's a type 2 diabetes diagnosis, but if it's for weight loss, typically they are not covered. And it just depends on if it's an employer plan, if it's a Medicare plan, if it's an individual plan. In the Medicare world, we have seen the government say, we're covering GLP-1s for weight loss. Then no, we're not. a week later. And now we're like, what's happening? We need to know for 2026 open enrollment's coming. And we just don't have a firm answer yet. But that will be, time will tell on that. And that's also really, really driving costs. What else? What comes to mind, Melinda?
Well, I know we're going to talk a little bit about some of the Medicare stuff. I know that
Yeah.
seems to be hot topic for many people. As you mentioned, this access to care being a big challenge. What's behind that? Why are we having such trouble these days?
Money. I
I
always
was
ask
hoping it was
myself,
more than money because
I always ask myself, if I can't figure something out, follow the money. So
right, exactly.
we think it has to do with the private equity purchasing the practices. The practices are then told, the docs are told, you had 15 minutes per patient, now you have 10. So they're trying to get more appointments in, and so it becomes more of a surface appointment.
Mhm,
And as the docs that have been self-employed for most of their career are now employees, they're leaving.
mhm,
We've seen this big exodus at Polyclinic. As soon as Optum bought them, they're leaving. And so trying to get docs in and then managing them
mhm.
to see as many patients as they can, and somehow that getting appointments is just I called UW the other day for my daughter, and it was a 3 month wait, and
Mhm.
it's an emergent problem. And so, I'm sure the pendulum has kind of swung one way, and I'm hoping it'll come back to the middle where there will still be some private practices that are easy to get into, and people that are willing to spend more than a few minutes with you. We're also seeing a lot of providers not accepting insurance anymore. And in that case, they're either concierge, they're a naturopath that also has an MD, and under the naturopath part, they're not accepting insurance, which makes it self-pay. And then it's only treating the people that that can afford them.
Mhm,
So it's a big shift in how we get care.
mhm,
Positive things are virtual appointments. We're seeing those are people are getting more used to them. That started during COVID, as you all know. And we're definitely seeing more and more people taking advantage of that, and it is less expensive. I mean, I've seen people like take their phone and show the freckle on their face, like, how's this look, to a dermatologist, and that does save money and time. And I think we'll get better at that as well. AI is a huge part of what's coming. We don't know if that will be better or worse. I mean, probably a little bit of both. I was with a client the other day who was telling me that Kaiser has um, AI in the room, so they don't have to take notes anymore,
mhm.
which is a good thing because then they're looking at the patient, kind of a knee-to-knee appointment rather than a provider doing this. And so in some cases, we can see that be a benefit, and in other cases, it's just it's a matter of, is there enough AI knowledge out there,
Yeah.
enough
So
data?
I want to ask real quick. I've got two questions for you.
Sure.
One, you mentioned concierge
Yes.
doctors, and I know that's been something I've been hearing a little bit more. For anybody who maybe doesn't know what that means, can you describe what a concierge doctor is?
Sure. Concierge provider is one that you pay monthly, like a subscription fee,
Mhm,
and you have access to their practice 24/7. They will often call in prescriptions. There's usually 2 to 3 docs, one always on call, small offices, drive ups. We're seeing a lot more of concierge practices that are starting. There's also, I believe, One Medical is one,
mhm.
is concierge, although they accept insurance.
Okay.
Many of the concierges don't accept insurance, and they provide all the preventive care and primary care, and then they will refer out if there's specialists needed, and that's why you still need to maintain insurance. But the actual there wouldn't be any co-pays, or I know many of them do treadmill tests and pretty extensive lab, all for the monthly fee.
Okay. Thank you.
And access to concierge is really good.
Okay. Good to know. So is that something that you're in favor of?
Um, I am for
Hmm.
access and I am for certain patients. Some clients will call me and say, I want to do this concierge. And my first question usually is, are you sick enough? Because if you go to the doc once or twice a year, probably don't need to pay for a concierge monthly. But if you're like my parents that are going weekly, it's been huge benefit for them.
Okay. Thank you. And then, so we've got some great questions coming in, and I'm going to make sure these are answered. Some of them I know we are going to touch on a little bit. So if I don't get to a question right now, I promise you it's because I'm going to link back to it. Um, Jeff was wondering, I know we'll talk a little bit more about Medicare, but you mentioned the limiting time with the patients. Does Medicare limit
Hmm.
appointments to 10 minutes? And if they do, is that stated anywhere?
That is an excellent question. My best guess is no. I've never heard that.
Okay.
A patient is regulated by time by Medicare.
Okay.
Medicare cares more about diagnosis codes and what you're in to be seen for. They don't necessarily mess with the doctors and their timing.
Mhm.
It could be something that's coming, but I have not heard that.
Okay. Great. Thank you. What's your take on, we have another question. What is your take on ICHRAs and choice plans?
Ooh, ICHRAs is what we call them. I'm on the fence on them, and I'll explain why. I'm a fan of employees having choice. Let me explain what they are first. They're usually individual plans, and an employer might say to employees, rather than me setting up a plan and choosing for you, I will give you cash. You go choose your own plan off the exchange that works for you. It sounds so good. What what doesn't work, in my experience, is that all individual plans are HMO style plans in the state of Washington. That means that you must stay in network or there's no coverage. And it doesn't sound that bad at first. You're like, oh, good, I'm go to Virginia Mason. I'm fine. I'll stay at Virginia Mason. Well, that means if you're skiing in Sun Valley and you break your leg, it's not covered. Not covered. And they get to define emergency. They say that emergencies are covered, but they get to define them. So, in my experience with individual plans, if you have someone who travels, has a home in another state, travels for work, the biggest advantage of an employer plan is the PPO. It's actually the opportunity to have coverage anywhere where you can choose your provider and get better benefits. And if your provider's not in network, then you can pay more or you can go find someone in network. The individual plans don't allow for that. So while it works for part of the population, it definitely does not work for everyone.
Mhm.
And typically in an employer, you have all kinds. We have one of each. And so just to not offer a PPO plan and then have them not available is is there's a hole there. It's missing. But I think the concept is perfect. We just need a better product.
Okay. So one of the things that we talked about previously is that so these individual plans through things like the Washington Healthcare
Yep.
Finder include full pay plans, subsidized plans. So what limitations do you think there are to these?
It's the access to providers. So when you go into the health plan finder and you choose an individual plan, you might say, my doc's at UW, so I'm going to choose a plan that works with UW.
Mhm.
But then maybe you break your wrist and you get referred to someone at Swedish, and Swedish isn't in your network now. You chose UW, now you have to stay with UW. And so what people don't realize is that there's zero coverage. It's not less, it's nothing. So it's really important to be aware of those individual plans, and they do work for certain percent of the population, but also like in between coverage. I use individual plans a lot. Someone who retires a little bit early and then wants to shift to Medicare at 65, I'll use individual for that situation. So there are situations, but in my opinion, it is not a full covered. It's not full coverage. And also, some providers do not accept individual plans.
Okay. So we have a question here about prior auths.
Mhm.
here, especially there in Washington, that
Yes.
there's a new original Medicare piece of this.
Yes.
I'm not from Washington, so I'm not up on what's happening there, but um, can you
So the
talk
government
about that?
is testing out something.
Okay.
In the past, if a procedure, a visit is covered by Medicare, in other words, Medicare says this diagnosis code is in our list, then the insurance company, whether it be a Med Advantage or a supplement, covers it. So covered by Medicare, yes, covered by your supplement. Medicare is trying to save money, as we all know. They're trying out a pilot program in 2026, and there are 6 states that they're trying it out with. Unfortunately, we are one of them. And I say unfortunately is because usually it takes time for Medicare to figure things out, and I hate to be the guinea pig, but here we are. So what that means is Medicare has listed a few conditions, diagnosis code that they are going to pre-auth. If Medicare approves it, then your insurance on top of that will approve it as well. But it's Medicare doing the pre-auth, which we've never seen that before. So the good news is it's like 7 conditions, I think. It's not a full list. It's not blanket. It's some conditions.
Mhm.
And we're still learning about it. Just came out. We'll know more a year from now, but I'm trying not to worry about it. How's that for an answer?
I think that's great. We'll see if additional questions come up related to it. Well, speaking of Medicare, I know
Yes.
as an advocate and working with a lot of different individuals, and even as an advocate for my own family, when we've had conversations about when should you start planning and the process for Medicare. So maybe you can speak to that about how do we as advocates help the families that we're working with, our clients, in terms of getting on to Medicare. What does that path look like?
Okay, that's a great question, and it's changing. And it's
Of
mostly
course.
changing because there's no one working at Social Security anymore. That that's not true. So this is the part that's not intuitive. As you're approaching Medicare, your first thought is, I'm going to go to Medicare.gov. No, you go to SSA.gov and you apply for Parts A and B of Medicare at SSA.gov. The trick to that is when. When do I do this? You're eligible for Medicare 3 months before your birthday. You're eligible to sign up, and 3 months after. Typically, I say to people, go 60 days, go to ssa.gov, sign up for A and B. When you get your ID card, let me know. And at that point, we decide on either a supplement and drug plan or Med Advantage, depending on the situation.
Mm.
The times when people wait and apply late for Medicare is if you have employer coverage and the employer's over 20 employees, then it is better to wait it out and keep your employer coverage until you're ready to retire.
Mm.
And at that point, I say, give me 60 days once you know your retirement date. And the reason it's 60 days is because it's just taking longer to get Part A and B out of Medicare. It's just a function of less employees.
Mm.
But it's still working so far. We've had actually pretty good luck getting Part A and B out.
Okay. Excellent. Um, Back to one step back to, do
Sure.
you happen to know any the other states that are part of this guinea pig program?
Do I know them?
Oh, somebody was able to put it in New
Oh,
Jersey,
perfect. Thank
Ohio,
you. New
Oklahoma,
Jersey,
Texas, and
Ohio.
Arizona.
Yeah.
Yeah, I appreciate somebody looking that up. I'm like, I have no idea. So great. That is, that is very helpful. So yeah, so the timing of this really does matter, and I think as advocates, it's good for us to know that I had no idea about going to
Yeah.
SSA.gov first, so that's
Can I add
fantastic.
one more thing?
Absolutely.
As advocates, if you're talking to a client that is debating whether to go to Medicare and they may have a choice, they could stay on employer or they could go to Medicare. Sometimes, if they're on an expensive medication, like Humira, for example, sometimes I will have them wait it out on the employer plan and apply later rather than sooner.
Mhm.
And the reason is because the drug plans that are out there don't work that well. They're getting better. They now have a 2,000 annual maximum out of pocket as long as it's a covered drug on the formulary. So it's better than it was, but it is one of those things where if you're paying $5 on your employer plan or you're getting a coupon from the manufacturer, then it's worth hanging on to the group plan longer. Once you go to Medicare, you're no longer eligible for the coupons.
Oh,
Yeah, it's a bummer.
good to know.
We've been fighting that one.
Oh, wow. Another type of plan that I've heard recently that I hadn't heard much about before are micro plans or small business
Micro
plans.
group, yes.
Micro groups, yeah. Can you speak to
Yes.
those?
So these are micro group plans are less than any business that's less than 3 employees. It could be one.
Mhm.
And when I have a situation where someone, let's say, retires at 60 years old and they're not eligible for Medicare, and one of the individual plans won't work for them because they live half the time in Palm Springs.
Mhm.
So let's say they're 6 months in Palm Springs and 6 months in Seattle. The individual plan won't work because they will not be covered at their California property. And I have had people be California for 6 months, then Washington for six, but it's important to be on top of it and it's a lot of work. In that situation, I will often say, what did you do in your prior career? Sometimes they're retiring from Microsoft early, or actually we're hearing of a lot of layoffs. And I'll say, like, set up a business and consult. Set
Mhm.
up an LLC, be legit under the state of Washington as a micro group, and then we can sell a small business plan that's a PPO.
Mhm.
It's the way we use them to avoid individual when someone has a small business and they have 5 years or 3 years till Medicare. Once they're on Medicare, once people are safely on Medicare, I'm comfortable. It's that gap time where I'm worried an individual might not work because people that retire young like to go places and do things.
Mhm. Yep.
Beth is laughing at me.
Yeah, Beth,
Yeah, no. So
share.
my husband decided, that he was not going to have a plan that covered us wherever we go, and we travel all the time. And he ran into a big problem. So I've always taken Molly's advice and buy whatever she tells me to buy, and it's worked. It's worked. I broke my leg in Switzerland, and it was great.
It worked.
It worked.
Now, I don't know if you mentioned this, but I think I heard you say, like I know I've heard of like, is it Medicare Gap insurance? Does that then cover those other places? How does that work?
So there's two, once you have A and B of Medicare, there's two ways to get coverage. One is Med Advantage, which is in the news all the time. These are network-based plans. They typically are $0. They don't cost anything. In exchange for not paying a premium, then you agree to stay in network, follow the pre-auth rules. You've been hearing this about United Healthcare.
Mhm.
They're strict. So it's a give and take, mostly you don't get anything for nothing. So in exchange for no premium, you follow their rules. The other way is a supplement, which is like the old school plan all of our parents had. And the supplement allows you to see any provider that accepts Medicare anywhere. There's no list. So you can decide on your own, I'm going to go to Mayo Clinic and get this done. And you don't have to tell the insurance company, you don't have to have it pre-approved. It's total freedom.
Mhm.
Along with those plans comes foreign travel coverage. So that's where, like in Beth's situation, there's coverage while you're out of the country. The Med Advantage, because it's network-based, doesn't have any coverage out of the country. And then in addition to the supplement, you need a drug plan. And those were the plans I was referring to that, could be better.
As I started off with this, there are so many pieces to this. It's no wonder
Oh my
that
gosh.
people get lost, and that's I just want to, plug this is one of the main reasons that patient advocates can be so incredibly helpful because there are all of these questions, and some of this can be research that advocates can help you with or help explain these things, and we have amazing people like you that know this. So even if we don't know, we can tap our networks and talk to Molly about this. So if you are a family member or a patient listening in today or watching this later and you get overwhelmed, like know that you are not alone. Like so many people, myself included, just get completely lost in this. I'm now on my husband's plan and he's through the VA. So I now have TRICARE and that's a whole nother set of things. I don't know if you know anything about that system for anybody. If you want to speak to, if you don't know anything about it, that's perfectly okay. But if we're
No,
on the
TRICARE is all
topic,
good. Thumbs up on TRICARE.
okay, good, yay. But it's a whole other system that we have
It is.
to navigate. So,
Yeah. I mean, it has some issues, but for the most part, I'm a fan.
oh, good. Good. Yeah, I just got a big booklet the other day, and I'm like, okay, that's my homework.
Good luck to you.
Thank you. Oh, well, you can still continue to post questions. I know there's a lot of concerns, a couple different posts in here about just the process of getting approved or denied for prior authorizations. And, you know, there's feelings that the system is very skewed for denials. I know there's lots of stories about just insurance kind of being here to deny everything, and that's why they create all of the hoops. Can you give any insight, any reassurance about the fears that people have about denials?
Yes, it's a huge issue. And I know we know for a fact that some carriers start with a denial.
Mhm.
Let's just start with a no.
Mhm.
It's so frustrating. I will say that after years and years of fighting these pre-auths, there is one sentence that if you can get to works, and that's medically necessary. Is it medically necessary? And in the end, it is the doctor's call. Getting to that is not easy because it's typically appeal after appeal. But in the end, if there is some way where the doctor can say, I'm putting my hat on this, this is medically necessary, and give some facts, I am a fan of just keep approving till you get a yes. Sometimes I will call and I'll get a no, no, nope, nope, nope. Get a yes, write the person's name down when it was said at the time. I mean, really what we're just looking for some sort of approval, and the insurance company is all about saving money. And there's been enough in the news lately and the United Healthcare incident that we're seeing they're a little better than they were. I mean, and United Healthcare has said we are going to do better in the pre-authorization area. But I think we've reached the peak, is what I'll say.
So, what other advice might you have for advocates who are working with clients that are trying to navigate insurance and things, whether it's pre-authorizations or getting thing approved after the fact? Like, what are some things that we as advocates can do to help this process?
I am a fan of having a case manager from the insurance company. Regence is really good at this. They will assign a case manager if there's some big claims and chronic conditions, and they're kind of a middleman. They understand the insurance, but they're working for the patient. And it would help if it were me as an advocate and I had someone in my camp that knew the condition and knew the insurance part and is able to get a pre-auth through, I would become friends with them. Premera has them as well. I think Aetna's okay about it. United Healthcare is working on them. But if you can say, can we please be assigned a case manager? That will lighten your load when it comes to getting things approved.
That is a fantastic piece of advice. Thank you.
Yes.
Another question from the chat says employers seem to be getting high double-digit premium increases
Yes.
this renewal cycle. So they have two questions. The first one is, what are employers doing to overcome this?
Well, we'll see. We haven't had our 2026 rate increases come by yet, but we're hearing they're between 20 and 40%. I mean, just massive.
Yuck.
In the past, the rate increases are based on the average age of all the employees. And this happens sometimes with small businesses that age. Like I have a couple of engineering firms, and as the engineers age, the prices go up. And then usually as they turn 65, we moved into Medicare, and that helps the employer premiums for sure. Even if the employer is paying for their Part B and their supplement, it's cheaper than keeping them on the group plan. Because on the group plan, since it's based on average age, everyone gets that increase, and even the 20-year-olds in the group.
Mhm.
So we work on that. I will say higher deductibles. People are looking for higher deductibles, higher out-of-pockets. HSA plans are somewhat helpful. But I think we're going to see some creativity this year because the numbers we're seeing are numbers I've never seen.
Yeah. So that's from the employer side. So the second question is, what options do employees have to overcome access challenges and higher out-of-pocket costs?
Oh, that's a great question. I mean, you're sort of locked into what the employer charges, and what kind of plans they choose. Let's see, what would I say if I was an employee? I would have, if it was a family on the plan, I would have, and that, both spouses are working, like take the insurance home, do the math. Is it better to put the kids under your plan or under my plan? Who has more taken out of their paycheck? Separating a spouse for sure, because typically the one spouse will have their plan covered by their employer, the other one by theirs, and then figure out which one's cheaper for the kids.
Mhm.
I am seeing kids that are under 26 staying on plans of their parents' plans, even when they have full coverage at their new employer. Take the employer coverage. It helps the employer because now you have a 26-year-old on there, and it helps the family because they don't have to pay that extra premium.
Mhm.
There are gone are the days where having double coverage was worth it.
Yeah.
Not anymore. So, if you get insurance from your employer and then your spouse has it, and you being on both plans is just a waste of premium for everybody, including the employer. So that's about all I can think of because the employee doesn't have a lot of choice.
Yeah, we are kind of locked into what what the
I almost always tell kids that ask me, they'll get a job and they've got, 6 choices. Which plan do I take? Hey, Molly, what do I do here? I almost always suggest they take an HSA, especially if the employer is contributing to the HSA. That's free money to the kids. Money goes in tax-free, grows tax-free, comes out tax-free. And the kids will have money put into their accounts. And a decade later, they're like, whoa, where'd that come from? They completely forget.
Mhm.
And it's cash they can use for anything towards healthcare.
Mhm.
It can be glasses, braces, whatever they want.
Mhm.
So I am a fan of the HSA plans, especially if the employer is contributing.
Do HSAs roll over? Because I thought they were
Always.
really
It's the only plan that's not use it or lose it.
okay. I always thought it was you use it each year or
Mm-mm.
you don't, so I've never really that hasn't been something I've looked into. Huh.
Yeah. If you've never been offered one, you probably wouldn't look into it. But if you have been offered one as an employer, it's worth looking into,
Yeah. Good to know.
especially for the young people.
Yeah, for sure, especially if it's a you never lose a thing, definitely.
Yeah.
We have a comment about an article about AI programs being used to
Mm.
do this denial of prior authorizations. Can you speak to anything in terms of AI in the insurance world on how this is working?
Oh, it is a hot topic for sure. I think what's happening, some of these denials we've been seeing recently in the last year, I would say, have gone to AI first. And that AI is no. And that's when the appeal process comes in. If the doc writes a letter or sends chart notes,
Hmm.
then it has to go to a human.
Hmm.
So don't ever take a pre-auth no as a final no, because it's not. And it's probably AI that did it. There's been a lot of pushback from patients on this, and actually the carriers and the docs as well. So I think that is an ever-changing landscape.
Mhm.
But I just tell people appeal everything, even a drug that's been denied.
Mhm. So, do you think that they're using that? I'm flabbergasted by that. I mean, I shouldn't be surprised, but that does surprise me that they would just implement that tool
Yep.
in such a way, because that's just so heartless. These are people that need these procedures, and you're making them go through such a long process. But because when you do that appeal, you have to do that. That's more steps, and we're already not feeling well, and we're already having to, you know, delay care.
Therein is the problem. As it becomes more about money, it's less about the patient.
Mhm.
And everyone can feel it.
Yeah.
It's not, it's not just the sick people, it's everyone can feel it. So, there's going to be some ups and downs that come along with AI, and some of it will be good and some of it will be bad. But it's one of those things where it's moving fast and we just kind of have to hang on and do the best we can.
Definitely, definitely. Jeff has a question. If you are on a very expensive drug and need to apply for a grant, as an advocate, is there a list of grants that you can obtain for expensive meds?
Yes, the list is from the manufacturer.
Okay.
So if the med is made by Novo Nordisk, on the Novo Nordisk website will be a list of ways to make it cheaper. There's copay cards, there's grants, there's financial aid. So if you think about it from the drug manufacturer's perspective, and if they're trying to get to critical mass using their drug and no one can afford it,
Mhm.
the only way to get to the critical mass is to make it affordable so they get enough people on it so then it gets approved and used more.
Mhm.
So it is if you go to the website, sometimes I know like Eli Lilly has a really good one, but start with whoever manufactures the drug. That's the best place to start.
Mhm.
We're seeing some drops of grants in some areas from hospitals and research, a lot what's going on in political world. But we have not seen that from the manufacturers.
Okay, good to know. Um, oh, I do see. Okay, so um, Mary's asking, I recently heard that Medicare coverage for hospitalizations, PT, skilled nursing no longer requires the same level of improvement metrics to maintain payment. What are your thoughts on this?
I don't know about that. Hi, Mary. Um, can you explain more? Hi.
Can you hear me?
Yeah.
Yep.
Okay. So I only just read this from a lawyer who I follow. I get his newsletter, and he said that in the last year or so, there was a precedent-setting um what do you call it? Like a case, right?
Right.
Where some Medicare patients were being denied additional coverage because they were not meeting
Oh,
those kind of crazy advancement metrics that we all know they have to keep improving at a certain rate in their physical therapy. And I think hospitalization is a little bit different, but in skilled nursing, there are certain metrics that I don't exactly know, but that's
yeah.
asking.
I
Yeah.
have heard this, especially in the physical therapy side of it. They have to be progressing to a certain point. And if they're not progressing, Medicare's saying we're not going to continue paying.
Right. But what
Yeah.
I heard from this lawyer is that that has changed. And now they don't, they can't set those same limits anymore. That's what
I
I
need to
was,
do some research on this. That is a
yeah.
great question.
Okay.
It might be state by state. I just helped my sister with this because they're still doing it in Pennsylvania. So it might,
Okay.
I don't know, maybe
This
it's
lawyer is based here in Washington. So maybe I should just go revisit it with him and figure out where he got that information, because I also haven't heard that elsewhere. And now I work for Gentiva Hospice, and our presentation on Medicare benefits is still that hospice is the only Medicare benefit where you do not have to keep
Yep.
improving in order to receive that benefit. But then when he wrote that out in his newsletter, it kind of surprised me, and I have to speak on this week, and so I was hoping to have the most up-to-date
Oh,
information.
I wish I could help,
But
but I don't
it's
have
okay,
any.
Molly. Don't worry. I'll look it up. Thank you. So good
So
to see you.
Thank
I
you. You
just have
too.
to I just have to say this is so fun because when Robin and I started Allied Health Advocates, Mary, Molly, and Linda Dahl, who's also on here,
Yep. I saw Linda's name.
they were 4 of our 10 advocates. So it's just really fun to see you guys. No, I mean, yeah.
I want
Thanks,
to make sure
Beth.
that I point this out. Thank you so much, Judy, for finding an article that goes over the decision that you're discussing at the moment. So there's already a link in there for some information on this.
Thank you so
Um,
much. I'll look at it.
And I
yeah.
noticed it's from CMS, so that's excellent. Thanks for finding that.
Yeah, thank you so much, Judy. One thing that we talked about a long time ago, and I want to make sure we circle back to it, Jeff was asking about, so if, for instance, if Medicare isn't requiring this 10-minute limitation, who's doing that? Who is enforcing that 10-minute? And I know I've heard insurance companies are pushing doctors to do that.
I don't think it's insurance company. I think
Okay.
it's the doctor group.
Okay.
And since the doctor groups have been bought by bigger organizations, that's where we're hearing it. I did happen to walk with my neighbor the other day, who's a cardiologist at Kaiser,
Hmm.
and he said Kaiser is pushing him to 10-minute appointments. And he said he is so overworked.
Hmm.
It's
They're overworked and we're not getting, the care that we need. And that's one thing that I talk to people a lot about when it comes to, we have all of these conversations about difficult patients. And then I always say, but we also have difficult providers.
yes.
And part of this that I always remind people to think about is that, imagine if you were in a position where your higher ups are telling you you have to do this really, really important work in this teeny tiny frame, and you're having to see people over and over and over again. And none of them are there because they're super happy to be there. No one goes to the doctor, just to share their great day that they're having. And that wears on individuals. So if you're at the end of the day and that provider is seeing 7 other people plus, they might be a little bit exhausted. So I always just try to remember people, it's like we don't know what has happened before then, and I can't imagine the pressures that providers are under to get through people so quickly. They can't like that. That can't feel
No.
good for them.
We think about this a lot. We're a little worried. We in the industry are a little worried about uncompensated care becoming an issue because we have, as these rate increases come out, especially with the individual plans, I'm going to have clients say I'm not going to buy insurance.
Mhm.
And in any other part of our lives, let's say it's our cell phone bill, if we don't pay our cell phone bill, turned off, it is what it is. If you don't pay your healthcare bill and you end up bleeding to death in the emergency room, they're going to treat you.
Mhm.
And if you don't have insurance, it will be uncompensated care. And I don't know how we're going to deal with this as we get further into these rate increases, but it's the one thing where there's ethics involved. It's not just you didn't pay your bill, you don't get to have it. You can't do that with healthcare. And I think that's where the problem lies in that the hospitals and doctor groups and private equity, they're trying to make money on the patients, yet it's not always a money-making situation. It's life-saving sometimes. And that I think that's where we're seeing the problems. And I don't have an answer. I wish I could solve it.
Yeah. I think we'd solve a lot of the world's problems if we could,
Yes.
the healthcare systematic problems if we could get to some of this, but I don't know. Um, S.M. McDonald says the Jimo, and I cannot pronounce this last name, Sibilis, please forgive me, rule addresses the PT improvement coverage for long-term care. Have you heard anything about this. I'm not sure
Mm-mm.
what this is. Okay.
That's in response to the question I asked about PT metrics.
Got
Oh,
it.
okay.
Yeah, so thank you.
Thank you. That's what I assumed. I just wanted to make sure that that wasn't a big case that I just don't know about. Any other questions or comments for Molly? We've got about a little bit of about 10 minutes.
Molly's been a really great resource when I've had family issues and or patient client issues, but I think it's good to know that there are people like her out there who are actually doing advocacy in the insurance world. So
Yes.
yeah, reach out and
Thank you.
talk to her. Yeah.
Carolyn, I see you unmuted. Did you have something to share? Corinne? Oh, no. Okay. Sure, Mary, go for it.
So Molly, I don't know if I missed it, but can you share what you are doing now? Because I may have some potential customers for you
Sure.
in the coming week. So yeah.
I'm a broker and I work in the small business market, so under 50 employees, individual, which I sell cautiously, and Medicare. So it's three markets I'm in. And as we're approaching Medicare open enrollment, you all might be getting a bunch of questions. It starts on October 15th and it goes through December 7th. And what we're mostly hearing is that if someone has a supplement, there's very few changes. Keep your supplement, don't look back. There will be drug questions, and it will be about formularies, what drugs are covered, what the premium is, and which carriers are in the market. We're seeing some just exit the market, in which case someone has to find a new drug plan. One thing to note is a lot of people will say to me, well, if my drug plan is $2 and I don't have any meds, why would I buy a drug plan? And the reason is because if you don't buy a drug plan when you're first eligible, then if you want one later, you will be penalized. And it's a percentage of the premium for every month you didn't have one.
Wow.
And it's basically to make sure that someone doesn't not take a drug plan for 10 years and then all of a sudden they get on this really expensive med and like, oh, by the way, I want a drug plan now. It's
Mm-hmm.
to protect, it's just to protect the getting selected against. So there'll be a lot of drug plan questions, a lot. And we haven't seen the plans yet, so I can't speak to them. We're just getting word. We'll know on 10/1 what's coming, but right now they're still getting approved by OIC.
Okay.
I had a question also, Molly, for you. Uh,
Sure.
just I'm curious as like how often, obviously, you're helping clients with a lot of this plan selection process
Hmm.
um, during the annual cycles, but during the year as well, are you getting a lot of concerns and requests for helping with finding care, using plan? Like, how do you support your clients in those cases, or are you sort of directing them to just case managers, as you mentioned earlier, or somebody else? Like, how are you helping patients, and are you even getting requests for help?
I get requests. So typically, if I do a good job in the beginning and find a product that works for the client, I'll start with who do you see? And then make sure we find a carrier that works with where they live or what provider they see. And the plans are working relatively well. I don't get a ton of coverage questions. And when I do, it's me that services it. And I have reps at all the carriers I sell with. So, my favorite five, I have a rep I can call and like, hey, this didn't get covered. Can you help me with this? What's going on? And it's been a lot of years of building relationships, and that's really helpful to me as far as the service work goes. But once someone is in a plan, I don't get a lot of complaints or service issues. I mean, it's relatively rare, maybe one a month. You'd think it would be every day, but luckily it's not. And I try and really do a good job placing them in a product that fits them because it's better for them and better for me. We both win in that situation. And then there's some that we just manage, like sometimes, like I said before, where we'll choose an individual plan until they get to Medicare and we just do the best we can. And then Medicare, we're like, yes, you're there. You can let the individual plan go. So it's just a part of working it through with the client and finding something that fits them. Oh, by the way, I'll say this too. There's a couple of new Medicare carriers coming out. One's called Devoted. One is called Scan Health. And they're going to market hard. They're brand new to Washington, brand new to any state for that matter. And a lot of clients will say, well, what about this new Scan Health? I'm like a 3-year limit. They have to be in business for 3 years before I'll even show them because some of them are fly by night and we have to be careful when these come up. A lot of times they have really tiny doctor lists, a really, really narrow network, but the price is good and they're great at marketing and their pieces are good and they advertise well and they make phone calls and it's, that part scares me.
I think that's a really, really great point because I know I hear about different groups all the time, and I have these conversations with family members like, oh, well, look at this. This is going to save me so much money. And then I try and go find some additional information like, hold on, wait a minute, before we
Yeah.
go messing with things, let's do a little research. Let's see. I like the 3-year rule. Let's make sure that this has been established for a while.
It's pretty conservative and they could be awesome, but
Yeah.
you prove it to me and then I'll sell it.
Yeah. Yeah. Definitely. So one of the things the question is, what does she find she does a lot? And I'm not exactly sure in terms of like which of these types of policies do you do the much, but I'm going to kind of tweak this question a little bit. But what are some of the questions that you get a lot? What are some of the issues that you're helping most people with?
Medicare is number one for sure. And it could be a function of my age. I'm not yet Medicare age, but a lot of my friends are approaching. So it could be just that I travel in that world of people turning 65. So a ton of Medicare questions. Mostly the biggest question is honestly on timing. When do I go? And usually I say to people, if you're working and your employer is paying your coverage, anytime someone is paying your coverage, you should take it.
Mhm.
And when that time comes, when you're ready to retire, then we go to Medicare. But if you're turning 65 and your employer is paying your premium, what the heck? Take it. Because once you go to Medicare, it's mostly on you. So a lot of timing questions, a lot of drug plan questions, tons of those. And I think it's just a function of they don't work that great. And then the other part is the retiring early. What do I do? And do I get in this individual plan? We'll see what comes along. We won't know that till 11/1. Open enrollment for individual plan starts on 11/1 and it goes through 12/15. Washington did shorten it this year. In the past couple of years, they've had till January 15th to get people settled. Now it is December 15th. So good for my Christmas, but bad for patients. And it's people just have to be a little bit more on top of it. I don't think we're seeing any carriers leaving. No, all the carriers are staying. We are seeing, like, for example, Regence Individual is making a big change. Last year, Swedish was not in network. So this is individual only. This year, guess what? Swedish is the only hospital in network. Like, what? How did you do that 180? I mean, last year they're like, no Swedish. This year they're like, only Swedish. So this is the part that's really important on individual is keeping up with who is in network. Because if you don't have out of network coverage, you better be sure to choose a plan that does have your provider in network.
How does that work? If they weren't network, but now they're the only ones that are, then you have to reestablish with all new providers.
Correct. So this is when during open enrollment, if I have a client on Regence and I know they're UW people, that I need to move them from Regence to another carrier because it
Right.
is only going to be Swedish.
Oh my gosh.
I know. It's really interesting. And once again, about money.
Mhm.
She said, I was talking to my rep and she said, UW asked for a ton of money and we just can't do it.
Mhm.
And then
Do
as
they?
VM is part of Franciscan, and then Multicare now is with Overlake, and now there are these just huge conglomerates, and they're like, we want this much money, and Regents is like, we can't do it in the individual market.
Are they a not like how does someone know that that has happened? Like, do they let people
They're
that
going
are
to send
insured know that, or is
letters.
that us as advocates? Do we need to watch that every year?
No, you definitely, this was the biggest one for this year. I would say the biggest change. So if it, if you hear someone having Regents individual, think about that.
Mhm.
But it's a big deal. And this is really funny. I was in DC for an event, and the CMS, Center for Medicare Services, was talking to us. And they said, all right, agents, can you please tell your seniors to open their mail? Go to the mailbox. And it cracked me up because, I mean, that used to be what, like, the highlight of my parents' day was going to the mailbox. But, they're not opening their mail, and this is where the information's coming.
Okay.
So just, be sure and tell people, stay on top of this. It's important.
Read your mail, read your email.
Open your mail.
Open your mail. Oh my
It cracked me up.
Oh my gosh. Well, Molly, thank you so much. This
You're
has been
welcome.
incredibly, incredibly informative. And we're just so grateful for your dedication to doing this work, your continued support with Health Advocate X, and just the knowledge and time that you've shared with us. So thank you so
Of
much.
course, I hope it was helpful.
Molly, is it okay if we share your contact information?
Yeah.
Jeff already asked how to get in touch with you, so maybe it can go out in the post.
We can add that in case you miss it. And I know you had also given us some additional resources, and we will put those resources in with in case you missed it, email, and it'll be the next newsletter, and we'll have it posted in case people want to continue to follow up and do additional research. So again, thank you everybody so much for joining us today, and we hope to see you at the next community conversation next month.
Thank you all for listening. I know it's a boring topic.
Thank you so much.
It's a very important topic.
Thank you.
Take care, everybody.